It's my pleasure to introduce Professor Ahmed Bastawi. He's going to talk about evidence, from evidence to impact, VERZENIO in high-risk HER2 positive, HER2 negative early breast cancer.
Thank you, Mr. Chairman, for your kind introduction. I would like also to thank all the team of EVA Pharma for inviting me. Again, I would like to thank Professor 𝐈𝐍𝐇𝐈𝐆 and all the organizers. So what we know about the burden of breast cancer in Egypt, if we look at the incidence of breast cancer, we have around 26,000 new cases annually, representing almost 1/3 of all new cases of cancer in Egypt, exceeding the most common malignancies like liver carcinoma, colorectal carcinoma, non-Hodgkin lymphoma, and others. And if we look at the characteristics of the breast cancer in Egypt, it is more or less matched with the worldwide characteristics. We have around 70% of the patients HR positive populations, and we have triple negative in 10% and HER2 enriched in around 1 out of 5 of every case of breast cancer. Again, the majority of breast cancer patients now with early detection are discovered in non-stage 4 stage, which means that all these patients are eligible for adjuvant treatment. Again, they are indicated for escalation of treatment. Yes, we have around 70% of our cases in Egypt having positivity for lymph node, which means that we need to escalate treatment. But what did the Oncology Society have in order to battle breast cancer? We have overall survival definitely, and logically is the gold standard for as an endpoint of any clinical trial of early breast cancer. However, in almost every clinical trial in early breast cancer, it was very difficult to elicit overall survival, whatever the modality we used. For example, comparison of anastrozole versus TAM, extension of hormonal treatment, letrozole post-TAM for 5 years. All these clinical trials failed to elicit overall survival difference in an individual basis, apart from adding ovarian suppression for either TAM or exemestane. And in order to elicit overall survival in a curative intent population, we should have meta-analyses. And if we look at the meta-analyses we have, for example, tamoxifen versus no treatment at 15 years, we have a delta difference of around 9%. Again, aromatase inhibitors versus tamoxifen, we have absolute difference of 2.1 at 10 years, and the extension of hormonal treatment failed to clinically improve the survival. We have only 0.6% difference. However, in adding ovarian suppression either to TAM or to aromatase inhibitors could improve overall survival by around 2 and 3% respectively. So in order to elicit difference in this large population, we should have meta-analysis. But if we look at the most recent clinical trials using targeted therapies, for example, if we look at olaparib versus placebo in the Olympia, we have an absolute difference of around 4.4%. Again, in Keynote trial for triple negative breast cancer, we have around 5% 5-year survival difference. And in Catherine, in HER2 positive population, not passing into complete remission, TDM1 could elicit a difference of around 5%. So what I want to say is that if we use the whole population, it is difficult in individual clinical trials to elicit overall survival. But if we use at-risk population, because all these populations are at-risk population, HER2 positive population not passing into complete remission post-neoadjuvant is definitely a high-risk population. And the triple negative and the BRCA mutant populations are high risk by definition. So if you select at-risk population, you could at that time elicit overall survival difference in individual clinical trials. So our role is to escalate treatment only in at-risk population. So if we look at HR positive HER2 population, we definitely know that if we have a positivity for lymph node, a higher stage, a grading, a higher grade, we have at-risk population. Again, if we have K67, especially in younger population, it is a high-risk population. Similarly, if you have PR negativity, it is a high risk in elderly and not in younger population. And definitely, if we have oncotype DX of 30 or more, we have at-risk population. So if we look at HR positive HER2 negative population, it is by definition the best prognosis amongst all breast cancer populations. However, if we look at the curves in all these characteristics, we definitely know that it is not equal, because if you have grade 3, if you have whatsoever at-risk criteria, the population is now turned into a more or less different population from that of good risk population. And we know that early recurrence reflects endocrine resistance, and we have around 1/3 of patients in HR positive HER2 negative population recurring within 5 years, representing around 3-fold in higher risk than patients with lower risk population. Moreover, we definitely know that triple negative population is a high risk population by definition, and if we look at-risk, high-risk population in HR positive HER2 negative population, it is more or less similar to early triple negative regarding recurrence and survival. Moreover, look here. If we look at the 5 years recurrence rate and the 5 years survival, the curves for early triple negative breast cancer and for early high-risk HR positive population are more or less the same. But look at the end of the curves, even early triple negative breast cancer will be relatively better, because in HR positive population, you still have a potentiality to recur even after 20 years. But in early triple negative breast cancer, if the patient passed 5 years or 7 years, the curves are more or less turned into be parallel to the baseline. So what we have in order to escalate treatment in at-risk population, all of us know the design of Monarchy study, which is including HR positive HER2 negative population, pre and post-menopausal population, with or without neoadjuvant treatment and no metastatic disease. Patients had 2 cohorts, cohort 1 representing around 91% of the patients. It includes the high-risk populations based on clinical pathological characteristics, like, for example, 4 or more positive lymph nodes. And if we have 1 to 3 axillary lymph nodes, we should have grade 3 or tumor size of more than 5 centimeters. Whereas cohort 2 included patients based on the proliferative index K67, you have 1 to 3 axillary lymph nodes and 20% or more K67 positivity, and the population should be less than grade 3 or less than 5 centimeter tumor size. Patients were randomized in a 1-to-1 fashion to abemaciclib 150 milligram twice daily plus endocrinal therapy versus the standard endocrinal therapy, with a primary endpoint of invasive disease-free survival and the secondary endpoints as shown here. And if we look at the patient's characteristics, it is more or less balanced between the 2 arms. We have a median age of around 51 in both arms. Again, we have a population of less than 65 in the vast majority of patients. A slim majority of patients were postmenopausal, and no chemotherapy was in a minority of patients, around 5% in both arms. Fortunately, the primary endpoint of the study was met, and if we look at the primary analysis after 2 years of abemaciclib in the year 2020, we have a delta difference of around 3.2%. And after 3 years, the difference is still increasing. We have an absolute difference of 5.2. After 4 years, 6.2, and after 5 years of treatment, we have a delta difference of around 7%. And remember that abemaciclib ended after 2 years, so we have a carryover effect for the benefit of abemaciclib after the planned 2 years period. And the benefit for abemaciclib was maintained across all the predefined subgroups, regardless of receiving neoadjuvant chemotherapy or not. and whether the patient is pre or post-menopausal patients, again, regardless of the hormonal compartment, whether tamoxifen or aromatase inhibitor, and this is one of the privileges for ipimaciclib, because if you know, we have two drugs having a positive clinical trials in the adjuvant setting, ribociclib and abemaciclib, and ribociclib cannot be combined with tamoxifen for the fear of QT prolongation, whereas abemaciclib can be combined with either abema or with either tamoxifen or aromatase inhibitor. Again, we still gain benefit in PR positive or negative, and regardless of the age of the patient, whether less than or equal 65 years, the benefit of abemaciclib is maintained. Again, if you have a higher risk of oncotype DX, moderate or low risk, all the categories get benefit from abemaciclib. But the dramatic results of abemaciclib didn't occur until a few months ago, when the updated overall survival in the last ESMO was presented. And in every conference for abemaciclib presentations, we have an absolute difference of around 1.3, but it didn't cut the cutoff point of statistical significance until the last ESMO, when lastly there was improvement in overall survival. We have overall survival events of around 301 in abema hormonal treatment versus 360 for the endocrinal therapy, with a hazard ratio of around 0.84%, corresponding to around 15.8% reduction in the risk of death with the addition of abema to hormonal treatment. Similar results, even better, was achieved in cohort 1, when we have around 86.4 versus 84.4% at 7 years, with an absolute difference of around 2 in favor of abemaciclib, with a hazard ratio once again of 0.83, corresponding to around 16.5% reduction in the risk of death with the use of abema-based therapy. And the value was achieved in all the pre-specified subgroups, regardless of pre or post-menopausal, neoadjuvant chemotherapy or adjuvant chemotherapy, the number of lymph nodes, grading, whatsoever the stage, all the events were in favor of abema as compared to endocrinal therapy alone. Regarding invasive disease-free survival in cohort 1, we're still gaining a benefit, and the curves are still widening in favor of abema, and we have now an absolute difference of around 7% at 7 years. If we look at the most invasive disease-free survival events, look at the distant recurrence, most of the recurrences were distant recurrences, which means that if you have if we failed treatment initially, the patient will be incurable, and abemaciclib could decrease the incidence of distant recurrence, contralateral breast disease, and leukoregional recurrence. And if we look at this curve, the green boxes are for patients alive with metastatic disease, and the light blue is for patients dying due to breast cancer, and the dark blue is for death not attributable to breast cancer. If we exclude deaths not attributable to breast cancer, we have around 30% fewer patients in abema arm living with metastatic disease. And if we look at the subsequent anti-cancer therapy in any line of treatment, look at the endocrinal therapy, it is lower in abemaciclib endocrinal therapy arm as compared to endocrinal therapy arm. Again, we have a lower patients receiving a CDK4/6 inhibitor in subsequent lines of treatment. And the importance of this analysis is that one may argue that, okay, you are telling me that abemaciclib is improving overall survival, but what if this improvement in overall survival is attributable to the subsequent therapies received in after progression? And if we look here, we could easily notice that patients in the abema arm received less CDK4/6 inhibitors. So if any interference with overall survival for the subsequent treatment therapies, it would be by the negative and not by the positive. Regarding the safety, no new safety signals. For abema, we know that the most frequent adverse events are diarrhea, fatigue, arthralgia, neutropenia, and some elevation in and some abdominal pains, again, a rare adverse events of thromboembolic events. And all the adverse events occurred early and mainly low grade, and they could be managed by dose reductions and dose interruptions. If we look at dose adjustment due to adverse event, around 43% of patients had dose reduction. Discontinuation occurred in around 18.5%. But if we analyze this 18.5%, we could notice that more than 50% of the patients didn't have a prior dose reduction. Again, around 2/3 of the patients discontinued treatment due to grade 1 or 2 adverse events, which are not an indication for discontinuation of treatment. What I want to say is that if we could adhere to the guidelines of dose reduction before discontinuation, the majority of these discontinuation wouldn't have occurred. Regardless of that, around 72% of patients could complete 2 years of abemaciclib. And if we look at the association between dose reductions and the dose adherence, we could notice that dose reductions were associated with more patient adherence. And the question now, we know from our experience with chemotherapy is that the more you increase the dose, the more you get response, obeying the dose response curve for chemotherapy. And the question now, if you have dose reduction, for example, 100 or 50 even milligram, would this dose reduction will be associated with decreased efficacy of abemaciclib? And if we look at this analysis, which assess the 3 dose intensities based on relative dose reductions, and if we look at the relative dose intensity curves, we cannot have overlapping more than that, denoting that dose reductions were not associated with decreased efficacy of treatment. So around 51% dose reductions were observed in patients, and the median time to occurrence of first dose reduction was around 2 months. And if we have dose reduction, around 93% of patients could adhere to treatment beyond 3 months compared to the 72% in the whole population. So definitely you are confronted by an unmet need in patients with N-positive high-risk disease on standard endocrine therapy, because we have a recurrence rate in 1 out of 3 cases at 5 years. Again, we will lose 1 out of 5 cases after 5 years, which is more or less similar to early triple-negative breast cancer. And if we compare N1 high risk versus N1 low risk, we have a 2-fold higher risk of recurrence in the high-risk population. So what to do? We have 2 years of abema plus endocrine therapy as a new standard of treatment, which improved all the endpoints. We have overall survival difference of around 2% absolute difference, with a relative risk reduction of around 16.5 at 7 years. And similarly, we have IDFS and DRFS of around 27 and 26% respectively, with an absolute differences of around 7 and 5.5% respectively. And the benefits was maintained in all the subgroups, and we have a privilege for this drug to be combined with either aromatase inhibitor or tamoxifen as compared to the ribociclib, which is only combined to aromatase inhibitors. If we look at the safety, we have a tolerable drugs, and the patients could adhere to the treatment if we have adherence to the guidelines of dose reductions. And whenever we have dose reductions, it will not be associated with decreased efficacy of the drug. And regardless of all of this, if you have overall survival difference, do not talk to me about any comparison, because whenever you have overall survival differences, the privilege is for the drug which is having improvement in overall survival. So in conclusion, abemaciclib is the only CDK4/6 inhibitor to demonstrate a statistically significant and clinically meaningful overall survival benefit. Again, abemaciclib achieved the ultimate goal in the curative setting with 2 years of treatment. Abemaciclib achieved sustained and clinically meaningful reduction in the risk of recurrence at 7 years, with a continued improvement in IDFS, DRFS, and the durable carryover effect. And we have now the most mature data for any CDK4/6 drug inhibitor in the early setting. And this is why it is a category 1 recommendation by NCCN guidelines and scoring A in magnitude of clinical benefit by the ESMO. Again, even NICE guidelines, which is the most commercial guidelines, adopted the use of abemaciclib in the early setting. And with this, I thank you for your attention.